Hello, and welcome to the second part lecture for the week of October 6th for the Intro to Long-Term Care class. Last week we talked about some intro facts about long-term care, talking about the difference between skilled nursing home and assisted living and personal care homes. We also talked about the types of roles and responsibilities pharmacy plays in nursing home care, from a distribution role to a clinical role. We talked about the various disease stages a pharmacist may be involved in, and we also talked about the needs of long-term care requiring from pharmacy. This week we're going to focus on one of the very first FTAG regulations and talk about the key components that's required by a pharmacist in doing what's called drug regimen review, or the other term medication regimen review. Back in 2006, the Center for Medicaid Services updated the FTAGs, and the FTAGs are the guidelines of what is required by skilled nursing home care. If you remember, it is skilled nursing home care that is recognized by CMS as what is called institutional care. And to be able to be licensed and to be able to bill Medicare and Medicaid services, nursing homes have to meet these FTAG regulations. And these FTAG regulations are guides. They help interpret what's required, and between them, the quality indicators that we're going to talk about later this semester, these are the things that are dependent upon a nursing home to stay licensed. Also remember, I said that the Center for Medicaid and Medicaid Services sets up these regulations, but in every state, the Department of Health is also who works with Medicare to enforce these regulations by inspections. When we look at pharmacy is composed of four main FTAG regulations, and those, like I said, there used to be numerous ones if you take a look at what the old tags were. And these regulations focus on the clinical requirements for pharmacy and also the distribution roles of pharmacy. Today we're going to focus on FTAG 428. And so FTAG 428 basically will go over the rules and regulations required by a nursing home to contract with pharmacy to provide clinical consulting services. Next week we will focus on FTAG 329, which will kind of give us our guideline map of what type of clinical issues we should follow when we are doing medication regimen reviews. So the next several slides we're going to talk about what those regulations are, and at the end of this talk we're going to kind of touch base on that nursing home case that I posted on Blackboard, so please have that posted. The other thing, I did receive an email from one of you guys from the other day on the first lecture, and so I will post the video lectures now, and I will post the PowerPoint, so in case you want to take notes during the recording. So FTAG 428 was basically says the following: the drug regimen of each resident must be reviewed at least once monthly by a licensed pharmacist. The other thing I mentioned last week is this regulation has been in existence all the way back in the early days when Medicare and Medicaid was passed in 1965. But over the years, it's evolved of what are the roles and responsibilities of the pharmacist, what are those clinical responsibilities, and also what are the responsibilities of other interprofessional players taking care of that resident, such as physicians and nursing, especially the director of nursing. And so the other thing that's required too that I didn't mention, this is one of the few areas in clinical pharmacy where a pharmacist will be paid, or the pharmacy will be paid for the pharmacist's services, and it's required because these services cannot be given away for free, due to a lot of times giving away for free is considered a Medicare kickback. So this is a place that pharmacy role and position is highly needed. So it says like before that the pharmacist must review at least once monthly the residents, and the pharmacist must review every resident according to the census. Does that mean that you can see everybody, like for example, in a 100 bed skilled nursing home in just one day? No, it's going to take, as we talked about last lecture, probably depending upon the time you take, it may take up to anywhere from 8 to 16 hours per month, depending upon the size of the home. And the average consulting pharmacist working for, uh, you know, a long-term care company or having their own company is usually about 1,000 beds per consulting pharmacist. That if this was a full-time role. And the other most important thing about doing this review is doing traditional clinical pharmacy is, are there any drug related problems? And if there are any drug related problems, the pharmacist must report any of those irregularities to the attending physician, usually in the clinical type of SOAP note, and there should be a summary report of what those recommendations were given to the physician to the director of nursing. And it's the responsibility of the director of nursing to make sure that these reports are acted upon by the physician. And in some nursing homes, you do have nurse practitioners and physician assistants that get involved, and so they also are held to, they must act upon your recommendation. It doesn't mean that they have to follow your recommendation. They may have some clinical differences of that, but if they do not follow it, they need to make sure that they document what's the reason for not making that, taking that recommendation at that time. As I said before, the director of nursing and the attending physician are not required to agree with the pharmacist's report, nor are they required to provide the rationale for their acceptance or rejection of the report. However, there has been, since 2006, that they have to make sure that they at least make a note of why they do. And so this may be accomplished by indicating any acceptance or rejection of the report and signing their names. The facility is encouraged to provide the medical director with a copy of the drug regimen review reports and to involve the medical director in the reports that have not been acted upon. I'll go into a little bit more detail about this later on in the slides. So, prior to 2006, you'll hear me say this interchangeably, but they're pretty much the same thing. But anytime new rules and regulations are made, sometimes the terminology changes. But prior to 2006, we used to refer to the pharmacist review as the drug regimen review, the DRR. Now, they changed it slightly and it's called the medication regimen review. And so what is a medication regimen review? Basically, it's the thorough evaluation of the medications per resident with the goal of obviously promoting positive outcomes and minimizing adverse consequences associated with these medications. So during this review, you should be able to identify, report, and resolve any medication related problem, any identification of any possible medication errors, and anything that might be irregular that be associated with the interdisciplinary team. And so sometimes some of those things would include, such as med-pass observations we talked about in the prior lecture. So what are these things we're preventing? We're identifying, reporting, resolving them. And how do we do those? First off, what is a medication related problem? We're going to focus next week on the unnecessary med category, and a lot that has to do with the unnecessary med category are traditional things that we think about in terms of clinical monitoring of a drug regimen. A lot of the things in the unnecessary med category focus on the Beers criteria. And FYI, I will be posting a link shortly between now and next week, but the American Geriatric Society has now officially released the updated Beers criteria, and it's actually available on the website of the American Geriatric Society. But for a medication-related problem, it's obviously the use of a medication without an adequate indication for use. It's the use of a medication without identifiable evidence that safer alternatives or a more clinical appropriate medication has been considered. So one of the things, a real simple thing, and we're going to talk about this when we look at the case, is when I first get a patient, it doesn't matter, um, you know, what everything's in the chart. The first thing I get from that patient is I get the list of their active medications and I get a list of their active medication problems, what not medical problems. And what I do is I do a matching game and I make sure that does everything have an indication. A good way to kind of study of how to start thinking about how to do a review is that article I posted by Dr. Hanlon on complex medication regimens. But basically, once I do that matching, I look at the medications and I think to myself and be able to answer two questions. What do I have to do to evaluate the efficacy of that medication? What do I have to evaluate the adverse effects of the medication? So let's take for an account hydrochlorothiazide. Hydrochlorothiazide is used for blood pressure control. So obviously the first thing I need to evaluate for clinical efficacy is blood pressure. I also need to look at that patient depending upon their age, their other medical problems. What is the target goal of that blood pressure? The second thing I need to look at is what do I have to monitor to see if there's any adverse consequences. And so I may need to get, an electrolyte panel because we know diuretics can possibly cause, potassium and sodium loss. We also know that diuretics can cause dehydration, so I may need to look at the BUN serum creatinine. We also know that hydrochlorothiazide may have drug disease interactions or drug interactions, and so I need to check that. So we're doing our good traditional clinical pharmacy review. Another definitions is the use of an appropriate medication that is not reaching treatment goals for reasons such as timing or technique of administration, or it's a not appropriate dosing interval. So perhaps a resident is suffering from insomnia and we have them on fluoxetine for depression, but the patient's taking the fluoxetine at bedtime, which we know that drug has been associated with causing insomnia, and we see the patient now is taking zolpidem 5 to 10 milligrams at bedtime. Another medication related problem is the use of medication in excessive dose. So we know that certain medications should not be used at high doses due to possible renal impairment. We know that there's certain high doses that shouldn't be used in geriatric patients based upon age, and we'll talk about those in more detail next week with FTAG 329. We look for the presence of any adverse consequences, and so we see a patient reported in the chart that they are suffering from falls. We see that upon interviewing of that resident, that resident reports to having, dizziness upon standing. And when we have the nurse check for vitals such as orthostatic hypotension, we identify they are orthostatic and maybe they are dehydrated, and for example maybe it's a diuretic and we either need to reduce the dose or discontinue the medication. A use of a medication without adequate monitoring, so making sure that the appropriate labs are ordered, to make sure nothing's going wrong and to evaluate efficacy. And so periodically, for example, we may have somebody on, levothyroxine for thyroid. What is the appropriate time that should be checked? We have somebody on a statin for cholesterol, and we just recently had a dose reduction about 6 weeks ago. Should we get a repeat lipid panel? The presence of risk for medication errors, and this can be done through the MedPass observation. This should be done by evaluating the documentation and the electronic MARS, the medication administration records. Presence of a clinical condition that may warrant initiation of a medication, and so we talked about underutilization of medications, and so we may need to identify a patient has had falls, has had a fracture, is diagnosed with osteoporosis, but is not being treated, whether it's with a bisphosphonate or even appropriate calcium supplementation. And we need to think about medication interactions. And so there used to be, and we'll talk about this in FTAG 329 next week, of the top drug interactions in long-term care. And I'll post a link to that next week. But we think about, drugs that are narrow therapeutic, drugs that are high risk for adverse consequences, such as warfarin. We want to make sure that there's no drug interactions occurring. And one real simple tool to start that is anytime you do a medication review, as you're starting to learn as a pharmacist to do this, is take all the medications, plug them into a Lexicomp software, plug them into Micrometric software, and run a drug or interaction screen. The nice thing about the Lexicomp software is when you throw all those drugs in, it will also tell you some of the other clinical consequences besides direct physical drug-drug interactions and give you some geriatric recommendations also in turn. The other thing we need to look at is for medication errors. And medication errors have different definitions. And the one definition is a medication error is any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in control of the healthcare professional, patient, or consumer. Such events may be related to professional practice, healthcare products, procedures, and you can read the rest. That is why there's the importance of the med-pass observation. In the med-pass observation, you, the pharmacist, would review periodically the nurse preparing and administering the medications. So, for example, are they using appropriate technique of administering an eye drop to make sure that the tip is not touching the eye, that there's no risk for contamination, that they're waiting at least 5 minutes between each drop so there's appropriate absorption? Are they using all the key steps into using an inhaler for that resident? Are they drawing insulin up correctly or using an insulin pen correctly? Are they rotating the site for the insulin shot? Simple things that are not done appropriately can lead to maybe not the drug working appropriately or maybe risk for error that the patient gets too much medication. And so you see the term in the regs, irregularity. And an irregularity is any event that's inconsistent with the usual proper or right approaches for pharmaceutical services. And this may impede in the outcome of these services. And so the term irregularity can focus on numerous things, such as in later FTAGs we'll talk about checking for out of dates in the med room. All right, and that can lead to obviously, ineffective drugs causing harm. So irregularity, it can also be interchanged a lot of times for drug-related problems. Given those definitions are important to note, the document also states the following in FTAG 428. This guidance is not intended to imply that all adverse consequences related to medications are preventable, but rather to specify that the system exists to ensure that medication usage is evaluated on an ongoing basis. We're not going to be perfect. We're not going to be 100% perfect, but the goal of the system is to reduce the risk for these irregularities. And what they want to see is that there is a constant goal with the pharmacist, with the other healthcare professionals in that skilled nursing home to take care of that resident. The next thing that's mentioned in FTAG 428 is the frequency of the review. Monthly or more frequently depending upon the resident's condition, the risk for adverse consequences related to the current medications. So I did say earlier that, according to the census, every resident should be looked at. But every week there will be new admissions to the nursing home. Every week there will be new residents with issues. Some of the tools that I would do when I would go to a home, usually I would have a specific day once a week that I would go to that home. Now that day could vary depending upon my schedule, but during that day I would do a couple things. First, when I reported to the home, I would go find the director of nursing and ask them, are there any problems that you've seen possibly be about any particular residents that they might have heard in nursing report, in any of their care planning meetings, so that I could look at those residents directly. The other thing that I would get from nursing is I would get a list of their monthly quality indicator report. And we'll talk about the quality indicators in a later lecture, but those quality indicators may indicate possibilities. So if I see numerous patients who've had recent new accidents related to falls, I want to prioritize my time to look at those patients to make sure that it's not medication related. The other thing is I would obviously go to the new admissions first to identify any problems, at least upon admission, because as I said before, in a skilled nursing facility, you're going to have your long residents that are there to stay permanently, but they're going to get people coming in for subacute rehab. And these residents may have ongoing, high acute clinical issues that need to be looked at first. And obviously, too, the other thing I would do every time I would go to a floor, I would find the nurses and ask them, is there any key things that you know that I may need to take a look at there? And so you need to kind of look at that schedule and see how can I work that into play. The other thing that says in the FTAG 428 is where to conduct the review. Prior, if you notice when we talked about the history in the prior lecture, it talked about that, you had to be in the facility, all right, and you couldn't just do paper chart review. You should go talk to the residents when need be, but it does say in the new FTAG 428 that because they realize technology, the ability to look at the electronic health records may permit the pharmacist to conduct some of those components of the review outside the facility. And so I would do that. I would actually, before I would go to the facility from the pharmacy, I was able to access, the medications. I was able to access through the electronic MAR to see what they got, especially say for example they were on a long-term pain medication and they had a breakthrough pain med regimen. I could look on that MAR and see how many times that PRN med was there, and I would make notes of that so that when I did go to the facility I could prioritize my time a lot more of which residents I needed to look at. So when we do a medication regimen review, we need to look at the sources of where do we get our information. And in a chart, and even if this is an electronic chart, these are the things that you will find. You'll have the medication administration record, so you'll see was, the medication actually given. Another thing that's important in this is that when it is documented, if say somehow somebody refuses their med or they forget to give the med, that has to be documented in the chart. Another thing that will be documented is PRN usage, and that is so important when we're looking at PRN usage such as hypnotics, or we're looking at PRN usage for pain medications. Obviously, the physician orders, we want to kind of do our own med rec to make sure things are being transcribed appropriately. And those physician orders in some facilities do come electronic, but there's still a lot of them that are paper charts. Now, in nursing homes, and this may evolve over the years, but traditionally the physician progress notes are probably some of the weaker progress notes. You're not going to see a lot of detail in them, but where you're going to see a lot of notes is with nursing. Nursing has to do daily reporting. You're going to see consultants such as psychiatry, physical therapy, nutrition. That resident assessment form, the MDS, that is another place to get a good baseline. And we'll talk about the MDS later on in the semester, but the MDS also has to be done at least every 90 days for a resident so we can see updates. Lab reports. You're going to look at reports for behavioral monitoring when we talk about psychotropic drugs. Any quality management or quality improvement reports. And obviously the other thing is you should go and talk to the resident and see how they're doing. And ask yourself, how many of these do I use, and should I be using more sources or different type than I am now? One of the things is every home charting is a little bit different. The location of those charts, sometimes when new labs come back or new reports come back, those are posted somewhere, like a folder or a clipboard for the physician to see when they come in. So different information may be located different places, and so you want to orient yourself to that home to find out where those are. The other thing too is when somebody gets newly admitted, usually they're coming from a hospital, so a lot of times I'll try to find the hospital reports that come back, and those are usually good discharge summaries, and there's some of the best information to get a good baseline of who your resident is and what are the clinical issues at hand. couple other considerations in doing your medication regimen review. Has the physician or staff documented objective findings? You want to make sure that the diagnoses are documented, symptoms to support the indication. So that's our role and responsibility too, that if a medication doesn't have an indication, we need to make sure that that gets appropriately documented in the chart, especially if there is an indication for that. Has the physician or staff identified and acted upon? Should they be notified about the resident's allergies, potential interactions, or adverse consequences? Is the dosing frequency, route, duration consistent with the resident's condition? Are they following manufacturer's recommendations? Has the physician or staff documented the progress toward the maintenance of these goals for medication therapy? Has the physician or staff obtained and acted upon lab results? Do med errors exist, or do circumstances exist that could make med errors likely to occur? So every resident we look at, these are questions and thoughts we need to take into consideration. The other thing is, you've just gotten done over the last couple of weeks talking about functional geriatric syndrome problems. And so if you identify in the chart documentation from reports, from consult notes about any of these geriatric syndromes, such as weight loss, behavioral changes, bowel function changes, confusion, you yourself as the pharmacist need to rule out, could any of these problems be associated with the medication? And if so, making recommendations to possibly get rid of that medication, substitute out another medication with less adverse effects, or possible dose reductions. And so you constantly need to be looking at that. A good place to get a report of those changes is from the MDS and also from nursing progress notes. And here's just another list of those problems. And like I said, our job is for all these problems, it could be disease related, but our job is to make sure they're not medication related. The other thing is the pharmacist is expected to document either that no irregularity was identified or the nature of the irregularities if they are identified. If none, the pharmacist would include and sign and date the statement to that effect. So somewhere in that chart, every month, you have to document that you did review that resident. And if you did review that resident, you would say to them, no irregularities found, boom, and sign and date. And so when a surveyor came in or somebody saying, did pharmacy see this, they could see the date and time that you saw them. If there is a problem, you may make a note, there is irregularity, please see my progress note. And so a lot of times what I would do when I would do medication reviews, there was a place in the chart that I signed to show that I did review the chart, and there was a place in the chart or in the physician's clipboard or folder that I would put the recommendations. And then we're going to talk about reporting later on the semester, but every month there would be a report that would actually go to the medical director and the director of nursing with a summary of all my reports. And there's a lot of clinical software out there for long-term care consulting that kind of will help tie that all together for you. The other thing is the timelessness of the notification depends on the potential or presence of serious adverse consequences. So, for example, there are times where I will still write the note, but because I know that physician may not be there with maybe for another 48 hours, because a lot of times these physicians are coming in and this is not their full-time job, I would, either contact the physician directly myself, or I would let the nurse know so that they could contact the physician. So for example, something that might need quick attention is bleeding from a resident on an anticoagulant, a possible allergic reaction to an antibiotic. And so you'll work with and collaborate with the facility staff to identify the most effective means of notifying and documentation. And also, too, this documentation may be done electronically. Now, I used to use a clinical software that would allow me to print or email my clinical notes, and also was a great way to track and summarize my reporting of what type of recommendations did I make per month, and also for a way for me to track the responses from the physicians or other healthcare professionals to my note. The pharmacist findings are part of the clinical record. And if it's not maintained within the active clinical chart, it has to be somewhere within the facility and readily available for any healthcare professionals or surveyors when they come into the facility. So you have to find a balance between encouraging the facility and other healthcare professionals to utilize your notes, where can they find your notes, and allow facilities flexibility to determine the consistent location that suits their needs. So for example, there was always a place in the chart where I would sign a document to show that I reviewed it. I even had a place in the chart that would allow me to have my own little personal progress notes. And then if there was a note that I needed to report, I would say see physician note, and I would actually either place that in the chart, or some places they had clipboards for the physician, so that's where they would go right when they came to that floor to see residents, and some had folders. And eventually, when they signed off on those, the policy we had was they would fax the note to the pharmacy where I worked so I could collect those notes. And those notes would eventually go onto the chart. And then between me and the director of nursing each month, we would follow up to make sure the physicians acted upon those. Because what it says in FTAG 428, it says the following: a physician either accepts the recommendation or rejects the recommendation and provides a brief explanation, such as an in-dated progress note. And it is written in the regulations, the physician has to acknowledge your note. It's not acceptable for the physician to document only that he or she disagrees with the report. They have to give some basis for the disagreeing. And for those direct care issues that do not require physician intervention, it's the director of nursing or the designated nurse that has to be addressed about those issues. So it could be a medication storage issue, which go to nursing. It could be a possible potential med error in terms of administration, that would go to nursing. So you need to determine where that note would go. So what happens about lack of action or rejection? What about if you have a physician that does not act upon your notes? And that has happened to me over time. What is the potential for serious harm? And so usually what I would do is I would kind of go the order of command. The timing, there's no time frame of when they should act upon it, but what I've been told by surveyors in the past, they should act upon it at least within 30 days before your next review. And if I don't get them acted upon it, I'll make sure that they actually get to see the note. If I think it's an issue with one physician, I'll set up an appointment to talk to that physician. But if I don't get any progress from that physician, that is when I may get the director of nursing involved or the medical director involved with that. Because the nursing home can be fined by the surveyors if a physician does not acknowledge those notes. Now, what happens if you write a recommendation and the physician says thanks but no thanks and disagrees with a note? Do you need to keep documenting that irregularity? And what says in the regs, it says a pharmacist does not need to document a continuing irregularity each month if it's deemed to be clinically insignificant or there's evidence of a valid clinical reason by that physician or healthcare professional for that rejection. And so what I would do is, for example, say that I saw a dose should be reduced due to renal impairment, and the physician says, I don't think that's necessary, I'm going to keep the dose to where it's at. I would take that note, and what I would do is I would follow still monthly that drug on that resident, and if I would notice any adverse consequences, then I would bring that issue back up. But I would not write every month the same issue because it had already been acted upon. And that's why you need good clinical software, a good way to track your recommendations so you can see that. So that's what the FTAG 428 says. But let's talk about some pearls of how do I sort through all these drug issues when I see a resident. So there's different types of medication-related problems that could occur. We have obviously overutilization, polypharmacy. We have underutilization, and we have inappropriate utilization. We're going to talk about inappropriate utilization in more detail, and we'll talk probably about all three of these topics in more detail in FTAG 329 next week. So when you look at, I said this in the prior talk, the total drug cost, we always have to be thinking about, can we help the nursing home? Can we help the resident, the patient, to save money? But we also have to make sure that they're using the right medication, and there's no therapeutic failures occurring and no adverse drug reactions occurring. So when you first start as a consultant, you want to make sure you familiarize yourself with Medicare and Medicaid requirements. That's the purpose of this class. You want to familiarize yourself with recent facility surveys, and facility surveys are actually public knowledge outside of maybe some key components that are kept internal. But you would want the director of nursing or the administration to share with you what were your last couple of reviews and see if there was any pharmacy issues with those. You want to familiarize yourself with how documentation occurs within that nursing home, where you would put your notes, where you would find other types of notes. You also want to familiarize yourself with lines of communication. Do people respond to email? What are direct phone numbers so you can get a hold of people? Where do you place notes? Do you place them on a clipboard, into a folder, directly into the chart? You want to get to know the medical and nursing staff. Identify yourself. Share who you are. One of the things that I think is important is try to find and set up a time to meet with each physician when they are in the facility and introduce yourself. Talk about the type of notes and where you put them. Make sure that they know how they can reach you if they have any questions or clinical needs. And you want to also set your dates and times for doing your drug regimen review or medication regimen review. Key people you want to get to know in the nursing home. There is the ADON, the Assistant Director of Nursing, and the DON, Director of Nursing. Depending upon the home, one is stronger than the other to make sure things get done. You also want to get to know there's always a medical director. And that medical director, usually that's not a full-time job. They usually have their own practice somewhere else. But that medical director is to help you facilitate your needs to make sure your reviews and everything's been getting done. You also want to know who's in charge of medical records and find out where you can find reports such as infection control reports, restraint reports, people that may be also on psychotropic drugs, behavior reports to evaluate the need for psychotropic drugs, when you need to attend quality improvement meetings. Most of the times it's required by states to have at least quarterly quality improvement meetings, but lately in a lot of nursing homes they have a monthly quarterly meeting, and this is a good meeting to attend. It can be long, sometimes it can be a little drawn out, but it's the best place that you get to see all the key players and the best place that you get to communicate your needs to help them take care of the residents. There might be other committees that you get involved in, such as infection control, and you want to find out where are your needs for that facility. When it comes to the chart, we are in a different era now. We still have paper charts. We have some facilities transferring over to electronic medical records, and they still may have a little bit of paper and a mixture. But you want to find things of where's the admission records. That's where you'll get your baseline demographics. Also, admission records is usually where you might find a copy of the discharge summary if they're coming from a hospital. History and physical exam. This is where you might get your key initial vitals, your weight, your heights to help you calculate doses. You want to find out where the physician prescriber orders are. You want to find out how they use MARS. Is it electronically? Is it paper? So you can look at things such as omissions, whether or not they're missing a medication. Look at frequency of PRN drugs. And then the other thing is it's required in a nursing home if they do use a PRN drug, they document and did it work. And then another key place where you're going to find a lot of information is the nursing progress notes. The nursing progress notes will have the following information in it. Sometimes you'll find vital signs tucked within those notes, daily progress of the resident's condition. This is where you might identify geriatric syndromes such as falls, confusion, constipation. You'll see documentation of functional ability of the resident and any resident complaints. So like I said, the chart within the chart, the physician or prescriber progress notes will help you find possible diagnosis of why they prescribe the drug. Usually when I go into a home, if I had been there last month, I usually will try to go back to all the notes that occurred since I last was there. Consulting notes are a good place to find resources, such as dietary may give you what their target plan is for weight loss. Psychiatry, a lot of times you'll find documentation of reasons why patients are on certain psychotropic medications. And a lot of times your consulting notes will have justification for medications. Clinical lab data, you want to find out where that is associated. And like I said too, you might find out too is that when new notes are done, sometimes the physician needs to see those notes, and so the physician, those notes may not always be right in the chart. They may be on the physician's clipboard in their folder, and so you may need to look at those notes that day and find out where are they readily available. The timing of your drug regimen review, your medication regimen review, there's been, one thing is you are always going to be reviewing them at least once monthly, but you want to find the right mix of when you need to do prospective things. A lot of times I would deal with the distribution pharmacy. In my past of working as a consultant, I've worked both directly as an employee of a pharmacy, and I've also worked as a consultant non-employed with that pharmacy. But one of the things that I would do is I would work with that pharmacy that if they identified issues just by doing a good, profile review of any issues, they would do that. And one of the big things that I would do every month when I did my prep before I went into the home, I would look at high risk medications such as the Beers criteria drugs or narrow therapeutic drugs, and those are the patients I would look at first. And like I said, one of the things too is when you're doing a retrospective review, you want to find out if you see a medication discontinued, go back and look at why. Did an adverse drug reaction occur? If there is a new medication started, make sure we find out all the who, what's, and where's. Is that the right medication? Is it the right dose? Because once they get started on the medication and they've been on it for several months, even though you may think it's ineffective, it's harder to get rid of it if you don't act on it readily. The timing of your reviews, it's written in the regs that no more than 100 reviews in one day. That makes sense. As I said, the industry standard according to Open Survey says 9 minutes per chart, but as you'll find out, I believe that for an older patient it may take 15 minutes, for a newer patient it may take 20 to 30 minutes. Factors to consider of how you prioritize your time in the home is, some patients may take more, some residents' time may take more, certain chronic conditions may take more. There's different floors that have more acuity levels. There are some floors in the nursing home, that's where your Medicare Part A patients come in, and so those are ones you may set aside more time. And so you want to become familiarized with each particular resident. So obviously when we do our medication regimen review, we want to think about those key steps. We want to assess whether ADRs are a cause of any symptoms. We want to make sure we match the problem list with a drug list. If they're on a drug but no match with the problem list, consider whether the drug is necessary. If it has a chronic condition and not on a medication, consider whether there is evidence-based drug to treat that condition. And you want to assess and monitor for efficacy, safety, appropriateness of that remaining medication. So you want to use all your clinical pharmacy knowledge and skills in reviewing each patient's chart. And finally, you want to use the principles of optimizing drug use in the elderly. Consider whether a drug therapy is necessary, promote the use of small number of drugs to treat common problems, adjust doses or dosage intervals for medications, establish therapeutic endpoints, and constantly regularly review the need for those chronic medications. Another nice tool, this tool is called the MAI, Medication Appropriate Index. This tool initially was created, and it has been validated in studies as a tool to assess appropriate prescribing in physician ordering. But this is a great set of 10 questions to ask yourself when you review each patient. Is there an indication for the drug? Is the medication effective for the condition? Is the dosage correct? Are the directions correct? Are the directions practical? Are there any clinically significant drug-drug interactions? Are there any clinically significant drug-disease interactions? Is there unnecessary duplication with other drugs? Is the duration of therapy acceptable? Is the drug the least expensive alternative compared to others of equal utility? So this is a nice tool, especially when we're first starting out as a pharmacist in reviewing medications. And the final note for this lecture is remember that every time you review a chart, this is a real person. This is a person that you're trying to do the two principles that we talked about geriatrics, and that is to maintain quality of life or to improve quality of life. And that is our role and responsibility as a consultant pharmacist. So finally, let's just take a brief looking at the nursing home case I gave you. So if you take a look here, this nursing home case, we have an 87-year-old, and this gentleman has several problems, and he has several current medications. And we're going to use this case to help ourselves with this week's lecture and next week's lecture. So I'm going to be posting on Blackboard your discussion questions for this week that I would like you to have posted before next Tuesday when I do post the next lecture. And what I'm going to have you do is kind of go in and start identifying some key problems or attempting those. I'm not looking for a complete accuracy because we have time, to go over that in more lectures. But I want you to start thinking about that so that we can get you up to speed. One of the things we're going to do at the end of this semester is we're going to actually do some real life in class long-term care cases, and so this will provide you, the start for that tool. Okay? So if you have any questions during the week, please don't hesitate to email me that we can communicate. Remember, on October 20th, we're going to do a live chat session, so we'll be able to answer some questions about that. And like I said, please look for the discussion questions that I'll be posting shortly. Thank you.